Evening, everyone, and thank you for attending AACP's webinar with Dr. Witt Wilkerson, presenting Creating Healthier Patients and Practices, Integrative Dental Medicine. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 45 minutes, followed by a 15-minute Q&A session. Dr. Wilkerson has no conflicts of interest. I would also like to briefly mention some upcoming events for the AACP. The Medical CBD Crash Course for Healthcare Professionals with Dr. Gregory Smith on June 4th. And our next complimentary webinar will be June 9th with Dr. Angela Tenholder on Invisible Influencers, Challenging the Paradigms of Oral Restrictions and Sleep-Disordered Breathing. I would like to introduce our speaker, Dr. Witt Wilkerson. Dr. Wilkerson grew up in St. Petersburg, Florida, where he spent hundreds of hours on the water and golf course. After completing dental school at UF in 1982, he joined the prestigious practice of Dr. Peter Dawson. Over the past 30 plus years, Dr. Wilkerson has taught classes at Dawson Academy, where over 40,000 dentists have studied occlusion, restorative dentistry, and TMD. The past 10 years, Dr. Wilkerson's focus has been directed toward elevating dentistry as a true specialty field of medicine and complete health, coining the term integrative dental medicine. He recently founded the IDM Scholar Society and authored The Shift, the Dramatic Movement Toward Health-Centered Dentistry. Dr. Wilkerson and his wife, Patricia, have been married for 31 years, have 3 children and 2 grandchildren. The family enjoys attending UF Gator football games and travel together. And with that, it is my pleasure to turn it over to Dr. Wilkerson.
Again, I want to thank you, Shaylin, for inviting me to participate. And thank you to the Academy for being able to join you all. I've been familiar with your Academy back to its founding years, probably 37 or 8 years ago, I would guess. And many of your founding members are great friends and colleagues. And so it's a pleasure to talk to such a esteemed group and to share with you some of the things that I'm passionate about. Tonight, we're going to talk about integrative dental medicine and how it can be brought into our practices. Many of you are doing a number of the things that we're going to talk about, but I just want to share with you how this is unfolding for many of us around the country and how we're implementing these concepts of expanding the model of dentistry to become really a true specialty of medicine. We'll give you a little bit more about my background. Yes, I was fortunate to join Dr. Pete Dawson back in 1982. And of course, you're all familiar with him and the fact that basically the philosophy of our practice has always been, is there a better way? And if there is, then that's what we should do. And so continuous students and always trying to learn has been our goal. And it's been a great joy to be engaged in what I think is the greatest profession in the world. I don't have any conflicts of interest. As I was reviewing the Academy's focus, I read over your mission statement, basically that your Academy is committed to the relief of craniofacial pain, temporomandibular joint disorders, and dental sleep-related disorders, as well as supporting the advancement of education, research, and dissemination of knowledge and skills in these areas. I remember back in the middle 80s that, of course, the focus of the Academy was on TMD. And as we see in the statement now, there is a central focus on sleep as well. And that just shows that we're growing in our understanding of this multidisciplinary subject of TMD and oral health. And so I want to share with you a little bit about my journey, particularly the last 11 or 12 years, that really parallels the Academy and what's been happening among our colleagues within your organization, and kind of see how we're overlapping and moving in the same directions, and perhaps introduce a thing or two that haven't been an emphasis for you all that you could consider. In 2012, I was invited by a colleague, John Tucker, who I'm sure you're familiar with, who is a fine clinician and focuses his practice on sleep disorders. He and I were having dinner in Boston, Massachusetts, and he said, you know, you're very interested, Witt, in whole health issues. You ought to come with me and attend the meeting of a new organization called the American Academy for Oral Systemic Health, or it's nicknamed AOSH. He said they've only had one meeting, but this year, which was 2012, they were meeting at the Cleveland Clinic, and the researchers there at the Cleveland Clinic Wellness Institute were going to be the keynote speakers over the weekend. And so I gladly accepted John's invitation and went to this 2-day meeting in Cleveland at the Cleveland Clinic and heard some astonishing news from the clinicians and researchers there. For example, Dr. Caldwell Esselstyn presented a keynote address. And Dr. Esselstyn had been the director and the chief of surgery at the Cleveland Clinic, one of the most prestigious positions in all of medicine. And yet one day he walked into the clinic and he said, I quit. I don't want to open up people's chests anymore and graft veins around their broken down hearts that are not operating and functioning properly. I want to understand why the plaque is there that causes the problems. Then we'll actually be healing people and not just patching them up. And as you can see, 10 or 15 years later, he actually wrote a book entitled Prevent and Reverse Heart Disease. In other words, he had learned some of the secrets behind the root causes of cardiovascular disease, heart attacks, and strokes, and he was able to implement that in his practice. Dr. Michael Roizen, who you see on the upper right on this slide, was the chief of anesthesiology at the Cleveland Clinic, as well as president of the American Academy of Anesthesiology. He worked together with Dr. Roizen in the OR on a daily basis. One day, Dr. Roizen walked into the Cleveland Clinic and he said, I quit too. I don't want to put people to sleep so that Dr. Caldwell Esselstyn can open them up to patch them up. I want to understand why our patients develop cardiovascular disease, atherosclerosis, and plaque around their arteries throughout their body. And if we can understand that and deal with that, address that successfully, then we can put ourselves out of business. And so this new idea of looking at the whole person and not just treating the chief symptoms or not putting out fires or addressing a problem that's developed and now trying to address really what we would call sick care medicine instead of wellness care medicine was a huge insight for me. As we listened through the weekend, we heard various researchers and clinicians talking about inflammation and diabetes and accelerated aging and reversing the clocks and having patients live to be well into their 90s in superior health and looking at that whole person in all of their facets. So the name of this discipline of medicine is integrative medicine. At the end of that weekend, Dr. Roizen stood up and closed the meeting by saying, you know, this room is full of dentists and dental hygienists, and we believe that you all spend more quality time with your patients than anybody else in the healthcare profession. And I want to challenge you, and here was his challenge, that you dentists should be on the front lines fighting the health crisis that is destroying our nation. When he said that 10 years ago, I felt like it was a calling. I really determined at that point that I would spend the rest of my career trying to understand exactly what does it mean for dentists to be on the front lines fighting the health crisis? How can we as a dental profession do that? And so I've been to meetings where it was cardiovascular surgeons and cardiologists and one dentist and diabetes specialists and endocrinologists and one dentist and Alzheimer's discussions and dementia discussions and one dentist, and trying to understand how could we be part of the solution through dental medicine. And as I listened and learned, I realized that there were many things that we could do that could be extremely significant. In fact, we in dentistry are on the front lines as primary care providers because our patients are trained to come to us for wellness care, not just when they have an emergency or a crisis or an episode. And so as I studied this, I realized there was a tremendous role for us as a specialty in medicine, in oral medicine, and that we could coin a term, integrative dental medicine, and plug right into what these researchers at the Cleveland Clinic and other places around the country are doing. And so we've been trying to develop a model that would be appropriate, that would be easy to understand and to learn, something that we really can implement in our dental practice settings and help our patients in a big way. And so let me just introduce you to some of the things that I learned at this meeting at the Cleveland Clinic. First of all, that inflammation is the new medical buzzword among researchers. Every speaker at that meeting that weekend, no matter what their topic was related to chronic disease in the healthcare setting, spoke about inflammation, systemic chronic inflammation, and the fact that inflammation appears to play a key role in most chronic diseases. As I thought about that, I realized we in dentistry, we know inflammation very well. We look at inflammation all day long, don't we? As we look at periodontal inflammation, and we understand it's red and puffy and swollen and easily bleeds and is unhealthy. What I hadn't really considered until that time was that inflammation that we see in the mouth is often a sign of inflammation that's present throughout the whole body. So inflammation in the mouth, as we know, can be related to inflammation of our arteries, inflammation that can affect the lining of our arteries, that can affect cardiovascular risk, that can move, that is, the pathogens that reside in our body, in our mouths, can move into the bloodstream and go out throughout the body. And we hear about that with the risk of infections of knees and hips that have been replaced, as well as hearts that have been damaged and operated on. And so there's a direct connection there between oral health and oral disease and systemic health and systemic disease. We also think about other systemic conditions like diabetes, and we know that there's a synergistic relationship between periodontal disease and diabetes. And so when we see a dental patient, shouldn't we be asking the question, I wonder what's going on with their blood sugar levels? I wonder if they have elevated blood sugar levels that could be influencing what's going on in the mouth. And if they do, we understand that diabetes, undiagnosed and uncontrolled, is like having shards of glass scraping the walls of your arteries all day and night. There's almost nothing worse systemically than uncontrolled diabetes. And yet millions of patients throughout the country have pre-diabetes or full-blown diabetes, have metabolic syndrome, and these growing disorders that are visible, that are leading to systemic disease that can be not only harmful, but life-threatening. And then we think about dietary concerns, and we realize that the number one source of systemic inflammation is a pro-inflammatory Western diet, where on the average, about 60% of the calories that we take in the Western world are pro-inflammatory: refined oils, refined carbohydrates, refined sugars, processed foods, additives to foods, fried foods. All of these things are modifying the genetics of the food that we're intended to use as fuel, and confusing things in such a way that we end up storing a lot of unused quote unquote fuel in our fat, in our fat cells, and in our livers, to the point of even destroying them. And so dietary inflammation is a huge subject for overall health. Of course, we're very familiar with the inflammation that comes from smoking and nicotine, and anyone who's worked with implants knows for sure that that patient that's a smoker is at higher risk for having implant failure or periodontal disease than any other patients that we see. And so the inflammation that comes from these different toxins that we're exposed to, starting with nicotine, is a great example of systemic inflammation. And then the subject that we're in this conversation all familiar with is sleep. and the importance of that 1/3 of our lives that we spend in bed and asleep, and the quality of that sleep, and the oxygen concentration levels that are maintained, and the quietness of parasympathetic tone versus turning on that sympathetic fight or flight. We're choking to death, your oxygen levels are dropping, and having fragmented sleep is a huge source, as we know, of inflammation from inflammatory factors driven by systemic inflammation that we see from turning on these hormones that can be so damaging to us in our overall health. Stress is a big thing in our culture, and certainly stress is a killer. Stress can be a cause for the release of cortisol and stress hormones, just like sleep disorder breathing. And so that's a huge factor. And lack of physical activity, we know, can be harmful. Some say as harmful as smoking is the lack of physical activity and movement. And so we live in a world, don't we, a society that's surrounded by inflammation, with sore backs and sore joints, and arthritis, which obviously is a type of inflammatory process, is something that we see commonly all around us. We like to call this inflamed aging. That is aging that is being accelerated because of inflammation caused by these numerous factors in the body. Very interesting is that we might think of this as a new topic, and yet Time magazine had a cover article called "The Secret Killer: The Surprising Link Between Inflammation and Heart Attacks, Cancer, Alzheimer's, and Other Diseases, and What You Can Do to Fight It." Guess when this magazine was published? This article was published in 2004. 18 years ago, inflammation systemically was seen as a major factor, chronic diseases and even life-threatening diseases in the Western world. And so this is something that I believe in your academy and all of our academies that we're working with, inflammation should certainly be a central topic. So in looking at this subject of integrative dental medicine and dentistry as a specialty of medicine, I tried to understand what were the least common denominators that were appropriate for us to focus on. We don't want people to walk away from this discussion because it seems overwhelming. We don't need to go to medical school to implement the principles that I want to share with you and that you already are implementing, but we need to make it simple. And so in an effort to do that, I was able to consider three major subjects that I think are most important for us in dental medicine. The first being Tmd and occlusion, right there with your academy. The second would be airway, breathing, and sleep disorders, right in sync with your academy. The third would be inflammation and infection. And I'm really not that sure how much emphasis that you all put on that topic, but I hope perhaps some of the conversation we're having tonight will stimulate even more. And here's what I found that was very fascinating as I began to look at these things, both from a study perspective, but also in seeing patients every day. I began to see that the key point was this, that inflammation and infection, TMD and occlusion, airway and breathing are linked. Very often we find patients that have all three of these major pillars in an unhealthy way in their bodies. And so I've tried to really study this and begin to observe in our patients these things and see the connections and how we can come up with solutions. I've written a book in 2019 entitled The Shift, which really means the paradigm shift for dentistry toward the dramatic movement of health-centered dentistry. And so that book has become sort of the cursor or the introduction to this subject, and I hope that it'll be helpful to many. In the book, what we've done to simplify, again, this subject so that we're all on the same page is to create a checklist. So we call this the IDM, or Integrative Dental Medicine Checklist. And as you can see, there's three vertical columns, and at the top of each column is one of our three pillars. So we have a column for infection and inflammation, a column for airway and breathing disorders, and a column for TMD and occlusion disorders. Then down the sideline, you'll see we have history, signs and symptoms, and evaluation clinical signs. So what I've done is tried to make a simplistic checklist that includes major topics that we would be familiar with or looking at or asking our patients about that would clue us in to red flags that tell us that we need to pursue this more thoroughly. At the bottom here, you see we have screening and testing. So if a patient checks off any pluses under our screening information, then we'll go ahead and consider doing things like home sleep testing or overnight pulse oximetry or heart rate variability or hemoglobin A1C testing or salivary testing for oral pathogens, imaging for TMD and airway joint type problems and airway type problems, et cetera. And then on the second page of this checklist, we have treatment options. And again, these are simplified, but just inclusive options for treatment that help us to understand where we might go. So if you'd like to get a copy of this, you can text Integrative at 22828, and we'll send you a copy of the checklist. So text Integrative at 22828, and we'll send you a checklist. But as we look at this, what I'd like to do is just cover each one of the three columns. And really, I'm going to minimally address TMD because that's really our home base for everything that we do. That's where we start and where you've started, I know, historically. And so I'd like to talk about airway and breathing disorders, something that you're familiar with, but maybe just give you the perspective that we're using on this. As we look at history, signs, and symptoms, we'll simply include in our patient patient evaluation history form for them to check off, are you a mouth breather? Do you know? Do you snore? Have you been diagnosed with sleep apnea? Do you experience daytime sleepiness? Do you sleep poorly? Do you have nasal congestion? Do you find yourself breathing in a forward head posture? Do you know whether or not you're tongue-tied? Do you have a chronic cough, which could be related to gastric reflux and a deviated septum? Then clinically evaluating, we'll look for some of the cardinal signs like a neck circumference greater than 16 inches for a female and 17 inches for a male, Mallampati score greater than 2, a scalloped tongue, a 40% plus tongue tie restriction, nasal stenosis, and skeletal profile showing a retrognathic appearance. So again, just simple screening, taking no time at all to be able to identify those that are at higher risk. And of course, we see these things all around us, don't we? And one of the things that we have come to really appreciate is the relationship between breathing disorders and bruxism and tooth damage and erosion type wear related to low pH coming up from the stomach, the relationship between sleep apnea and sleep disorder breathing and gastric reflux and upper airway resistance syndrome as a type of pre-sleep apnea that is probably even more common than sleep apnea, as you know, and the inflammation that comes from this disordered, challenged breathing, drops in oxygen saturation, turn on of the adrenals and cortisol and the sympathetic response. So this is something that we're acutely aware of. And as we look at inflammation, even inflammation that may be related to gastric reflux and the signs that we see in the posterior pharyngeal areas, and put all this together, we realize that we're looking at a whole body concern that's manifesting itself very obviously in the oral cavity. And so we begin to think about the linkage between inflammation and infection, TMD and malocclusion, airway, breathing, and sleep disorders, and how in so many of our patients with problems, they're linked. Here's an example. This was a 21-year-old young female that was referred to me for TMD by another dentist locally. Her chief complaints were clenching and grinding, morning headaches, sore muscles, and poor sleep and fatigue. When she came in to see us, she reports that it's been so exciting lately with her symptoms that she actually woke up in the middle of the night the week before she saw us with distressed breathing and feeling like she was dying. She went to the ER in the middle of the night, panicked. And there, as she met with the ER physician, they did a number of tests only to find that they were all negative and told her that their diagnosis was that she was having an anxiety attack, and they gave her medications for anxiety. When she comes in to see us, I'm sure just as I can see, you see it as well because you're well versed in this, but there are 5 signs of possible airway, breathing, and sleep disturbances that we see in this one view as she opens her mouth. 1 being she has a severe tongue tie, 2 being she has a scalloped tongue, 3 being she has a Malampati 4 soft palate, 4 being she has an omega-shaped maxillary occlusion, and 5, which is not as obvious, is that she has incisal wear in a crossover position on number 6 through 8. So she goes into a crossover position where she bruxes. Why would you do that in a non-functional position? Is that parafunction just beside normal function? Or is it really protective function as the body's trying to open the airway for breathing during sleep that is distressed? And so as we see this in our dental office, in a oral medicine office, all of us that are educated on this, which each of you that's listening to this webinar are, I understand, are able to see something that the ER physician was not picking up on, was not familiar with, and yet there are red flags all over the place. And so as we look at these problems and we find positive responses and signs as we're looking at airway, then that leads us into screening and testing. And in our screening and testing, we have a number of options. In this young lady's case, we used a watch pat 1 overnight. And the next morning, as we received the report and the interpretation, it revealed that her AHI was 32. As you know, that's severe sleep apnea. And so we've diagnosed a severe sleep apnea problem in 24 hours. Very, very simple, through just being aware of and being able to have the tools and resources to investigate these things and then collaborate with our medical colleagues in an appropriate way. And so we referred her to a sleep physician to get the full diagnosis and interpretation of the sleep study, which, as we know, would be the appropriate steps to take next. And then we go from there. There is a role for us in this, and that may include working with expanding of the dental arches. That may include working with therapy for retraining her to breathe through her nose, working with her ENT, closing her mouth, and working with an oral myofunctional therapist. So all of those things that you're aware of, and working with the upper airway, with the posterior airway, with the oral airway, are things that we would talk about together with her tongue tie release, et cetera. And so doing sleep studies is something that I know is not legal in every state of the union. It is in Florida, but it's something that we're doing on a regular basis in our practice. We're screening every patient through just using Epworth Sleepiness Scale or the Stop Bang on men over 50. And every patient who comes back with red flags from those quick screening 1-minute tests, then we're recommending to do home sleep testing to see what the results of that are, and then to take it from there. And so mouth breathers, anterior open bites, tongue thrusts, bruxers, TMD, malocclusion, all to us speak of, could there be an airway problem? Could there be oxygen desaturations? Could there be decreases in pH in the esophagus that are driving bruxism, for example, and driving distress and driving hyperactivity during the nighttime and creating headaches and sore muscles and damage to joints? So home sleep testing is something that I would hope in the future every dental office would be engaged in and be legally able to screen at least, and then work with our medical colleagues. And so we call this a type of inflammatory cascade. So I come back to the idea of systemic inflammation, and we see here before us manifested in our patients' oral health or lack of signs of this inflammatory cascade, in this case through airway and breathing disorders. Treatment-wise, then we have options for airway and breathing disorders, sleep disorders. I divide it up into management and resolution. Management can be everything from encouraging nasal breathing, mouth taping, oral appliances, and then working with the ENT and airway specialist, allergists, oral myofunctional therapy, and the sleep physician. As far as resolution, then we're encouraging our patients when they're open to this and good candidates for looking at expanding their oral airway, expanding their upper airway, expanding their posterior airway, releasing tongue tie as some of our treatment options. So again, with the checklist, what we're trying to do is just kind of lay out the groundwork of options and to make sure that we're looking at all of those options. As we look at the checklist again and look at inflammation and infection, I've alluded to this as far as the fact that we are right on the front lines looking at inflammation as we look at the health of the gum tissues, as well as infection that may be there, or periapical infections that we see radiographically that no other healthcare providers are looking at. As we look at the list of history, signs, and symptoms and clinical signs that we observe, then that can lead us to understand that there's questions that we have about this that have to do with inflammation and what's going on in the rest of the body. Could this be a patient with diabetes? Should we be evaluating for that? Could they have periodontal or periapical pathogens that are communicating with the vascular system in such a way that there's an inflammatory cascade that's being initiated in the mouth and being disseminated throughout the body and actually is involved in the development of plaque and the response of inflammatory mediators and the growth of plaque and the unstable plaques that develop and coronary syndromes that can develop as a result of that. If you're not familiar with Dr. Brad Bale and Dr. Amy Doneen, they would be two great people to invite to come to one of your meetings in the future and speak. Brad is a cardiologist and Amy is a nurse practitioner with her doctorate in cardiovascular risk, but they've written articles on high-risk pathogens and their relationship with atherosclerosis and cardiovascular disease, talking about periodontal disease generated by microorganisms that can enter the general circulation and cause a bacteremia and can be independently associated with arterial disease. They speak of 5 high-risk pathogens, AA, PG, TF, TD, and FN, which have been shown to be very important in the dissemination of oral pathogens from the mouth into the cardiovascular system and to be part of the pathogenesis or the inflammatory cascade that is initiated in the mouth. And so they make a definitive statement in this postgraduate article in a medical journal that periodontal disease due to high-risk pathogens is a contributory cause of atherosclerosis. And distinguishing these type of periodontal pathogens provides a significant opportunity to reduce arterial disease. And so Dr. Tom Neighbors, another wonderful researcher clinician, Tom lives in Nashville, Tennessee, has spent over 40 years studying periodontal pathogens and the significance of those. And what he has most recently shared with us is the fact that even though we've studied 11 or 12 key oral pathogens, that it's really these five that are driving the ship of both periodontal disease and arterial disease coming from the mouth. And so these are defined as red complex pathogens or keystone pathogens or high-risk pathogens that actually, when these pathogens are elevated in our oral biofilm, they are able to actually determine the inflammatory nature of the whole biofilm community, because they're able to communicate even to non-noxious cells or bacteria in such a way that they can transfer information and cause an inflammatory response throughout the whole community through cell signaling and cell transduction, horizontal gene transfer, and quorum sensing, things that we could spend hours talking about. But the fact is these 5 key pathogens are driving the ship of not only local inflammation infection, but also systemic coming from the mouth. And so we see that there's a strong cardiovascular connection with these 5 high-risk pathogens. Bale and Doneen describe atherosclerosis as illustrated like a tree, where the fruit on the tree is atherosclerosis in the arteries, but you see the trunk of the tree is inflammation. But what we want to understand, as Dr. Esselstyn and Roizen emphasized so many years ago at the Cleveland Clinic, is what's behind the disease, what's behind the inflammation, what are the root causes? And as you can see, there's a number of root causes that relate directly to what we do in dental or oral medicine, such as obstructive sleep apnea, such as decay and abscesses and periodontal disease that can be driving inflammation, and a type of inflammatory cascade that makes us more susceptible to disease. Understanding that 80% of American adults over 35 have some form of gum disease. Oral bacteria has been implicated now in the development of Alzheimer's and dementia, and that people with gum disease are twice as likely to suffer from heart disease. And so with those facts, now today, through the work of Dr. Neighbors and others, we're beginning to really emphasize in our clinical practice and in our teaching salivary testing for the purposes of identifying these 5 high-risk pathogens. And so some of the companies that we're working with, including Oral DNA Labs and now Direct Diagnostics, which is run by Dr. Neighbors and his team, are identifying the 5 high-risk pathogens and then how to successfully eradicate them, to the point where today Dr. Neighbors would challenge each one of us by saying, can you heal or cure periodontal disease? And he will show you cases of patients with elevated levels of these high-risk pathogens that have been diminished down to literally negligible, and then held in that state for 5, 10 plus years, in which case you would say, not only is this disease arrested, this disease has been eradicated, or we might say cured, which is something that we've never considered. What a huge paradigm shift that would be. And so when we think about non-surgical periodontal therapy today, in the past, we've used just primarily mechanical and chemical means of attacking bacterial pathogens. But today we understand that when we look at this, some of these, in fact, 4 of these 5 high-risk pathogens reside in the tissue, to the point where you cannot get to them with a laser, you cannot get to them with root planing and curettage, you cannot get to them with oral antimicrobials, you can't get to them with a water flosser, you can't get to them with an electric toothbrush. In fact, they're impervious to these things. And so the disease continues, and the risk factor systemically as well as locally is elevated. I used to think that oral antibiotics, systemic antibiotics for oral infections such as periodontal disease, was like using an elephant gun to go after a mouse, and that it was literally, in my opinion, inappropriate. The problem was when we began to measure, to test for these oral pathogens and find some of these very virulent systemic risk oral pathogens, high risk oral pathogens, I would do all the non-surgical things that we could, even surgical things that we could, and all the different intraoral modalities that we had available. And when I would retest salivary testing these pathogens, they would remain elevated. When we began to understand that these microbes, these pathogens, are dangerous not only to our local but our systemic health, I realized that the only way that we could knock them down in many cases was through oral antibiotics, along with the other modalities that we're talking about, and that we weren't dealing with a mouse, we were dealing with a true elephant as far as systemic inflammation and risk. One of the interesting things is, as we recognize these 5 high-risk pathogens as being the elephant in the mouth and in the body, we understand that AA is a microbe that resides in the periodontal pockets. And so we can use amoxicillin, for example, and attack and defeat, knock down to 0 AA. But interestingly enough, the other 4 pathogens that reside in the tissues, and you cannot get to them directly, are impervious to amoxicillin. And in fact, metronidazole is successful in knocking them out. I find this ironic, and I'm sorry we don't have time tonight to adjust this further, but isn't it interesting when we give a patient an antibiotic because they've had a hip replacement or knee replacement, or they have some kind of heart issue, and we're going to clean their teeth, we routinely use amoxicillin, even though the truth is today that 4 out of the 5 dangerous pathogens that we're trying to knock down and prevent having an acute endocarditis or an infection they are not even being touched by the antibiotic that we're routinely giving. So that's just something to think about. Today, we're using trays such as Perio Restore with hydrogen peroxide trays that are placed in the mouth, and we're seeing wonderful results using these trays and this highly oxygenated environment, this healing anti-inflammatory effect of trays, as well as using antibiotics. And we always give a systemic probiotic whenever we give a prescription for a systemic antibiotic. We're using root planing and curettage. We're using antimicrobials such as Stella Life, which is a very healthy non-alcohol, non-medication health type product for inflammation and infection. Electric toothbrush, water flosser. We're using oral probiotics. Biora Pro makes a wonderful oral probiotic. And we're combining all these things together to fight oral infections and to fight systemic infections. I want you to hear for a moment from Dr. Brad Bale as he talks about the role of dentistry in complete health and cardiovascular.
Yeah, Witt, you need to understand, there's no question, oral health is a critical element in beating the heart attack gene, not only heart attacks, but strokes. And actually what we're finding now that's even more exciting, it's an integral part of preventing microvascular disease, which is what accounts for almost all the severe diseases of aging, from dementia to heart failure, to kidney failure, erectile dysfunction in men. Oral health is a vital element in that as well. Not just the big dramatic, oh, you had a heart attack, you had a stroke, but the more subtle damage that occurs over decades and then robs us of our health during the last 10 to 13 years of our life. If you want to have a health span that matches your lifespan, you better have excellent oral health. You know, we published the paper showing how the high-risk periodontal pathogens actually cause arterial disease. It causes arterial disease, of course, is going to heighten the risk of not only heart attacks and strokes, but that long-term subtle microvascular disease leading to those chronic diseases I mentioned earlier. So everybody really needs to be seeing an oral health care provider who is aware of that. Their team is literally helping to save lives by diagnosing high-risk periodontal pathogens and then managing those to eradicate them from our mouth. It's extremely important. And then the endodontic disease, of course, is vital as well. And we have great evidence. Endodontic lesions like periapical abscesses can trigger a lot of heart attacks and strokes. We even have evidence now indicating they're triggering peripheral arterial disease events as well. So the endodontic disease is very important too. And you have sophisticated tests to diagnose both the high-risk periodontal pathogens and endodontic disease. So you've got your salivary testing for DNA to identify the pathogens that can drive that periodontal disease with high-risk pathogens. And you've got the 3D cone beam, which is 96% accurate in picking up periapical abscesses. So oral health is critical for arterial wellness, for maintenance of health throughout our lifetime.
I hope that you can see and hear from Brad's words that it's time for dentistry and medicine to begin to collaborate together on an equal playing field where we have a tremendous amount to contribute to the field of medicine. We're beginning to expand our model now as we look at some of the reports back from such as the Cleveland Heart Lab. Nearly 50% of all heart attacks and strokes occur in patients with normal cholesterol levels. Evidence goes beyond lipids to suggest that inflammation within the artery wall is the primary contributor to this residual risk for heart attacks and strokes. Inflammation contributes to both vulnerable plaque formation and to plaque rupture. And so there are inflammatory markers from blood and urine panels. And we're beginning to look at this and say, when will it be time for us in dental medicine and oral medicine to begin looking at these inflammatory markers that not only increase the risk of periodontal disease, but also increase the risk of overall systemic inflammation? Aren't we the gatekeepers of systemic inflammation as we're looking in the portal of the mouth into the rest of the body and trying to understand what things are at risk for our patients? And so on the right-hand screen in yellow, you see some of these panels that we're looking at now, the ones that Dr. Bale and Doneen are using in their practices, and they're having conversations with us now about when will we in dentistry begin to engage in these types of inflammatory studies. Another type of inflammatory or arterial study, when we're looking at a CBCT and we see some changes, calcification in the carotid arteries, is that enough? And so I'm working with a nurse practitioner, Dr. Gina Pritchard, and she's doing carotid intima media thickness scans. This is an ultrasound of the carotid artery. Some dentists around the country now are starting to have these scanning days brought into their office where their patients can come in and have their carotid scanned and tell them if they're at risk for having coronary and vascular disease. And so treatment-wise with inflammation, infection, we're looking at a lot of lifestyle issues, counseling and anti-inflammatory diet and anti-inflammatory lifestyle, of course, eradicating infections in the mouth, eradicating abscesses in the teeth, etc. But as we wrap up this discussion that's been very brief, we're looking now at more and more testing, because diagnosis is what it's all about. And that's how we're going to gain great credibility among our medical colleagues when we're sharing the reports of our scientific studies that we're doing and the implications, whether it's an Airway report, whether it's an oral pathogens report, whether it's a report on vascular plaque. These are all different facets of this very important inflammatory cascade, and something that we want to be part of and on the front lines. And then, of course, the third vertical column is Tmd and Occlusion Disorders. And so this is something that you all are very familiar with, and the testing that we do and the options that we have for treating temporomandibular disorders. You all have mastered that in your academy, and I applaud you for that. And just want you to know that as we're developing this integrative dental medicine model, we're never going to throw the baby out with the bathwater. We're always going to pay attention to the health of the joints, and internal derangements, are important, and occlusion is important. And though we have a great interest in airway and breathing and sleep disorders, we're still not going to ignore the other end of that masticatory system. And so that's critical. But as we do look at TMD and occlusion issues, we also want to be thinking about other parts of the system that relate to this inflammatory cascade that can make our patients uncomfortable, that can cause our patients to have headaches, that can create sore muscles and fibromyalgia type signs and symptoms. And the list goes on, from regional pain syndrome and CRIPS, et cetera, and how big of a role does inflammation play in all of this, and how are these things linked in some of our more complex patients. So thank you for listening to me tonight, and I would be more than happy to take a few questions before we wrap it up.
Great. Thank you so much, Dr. Wilkerson. We do have a few questions. The first one is, when doing your scaling and root planing, is there a timing pattern to it, or do you have no specific timing in how quickly they complete each quadrant?
Yeah, that's a great question. And basically, think of this like you would think of cancer. So someone has a cancerous tumor, we're going to attack it in every direction we can, through radiation, through chemo, through surgery. And yes, in that case, there may be sequencing to it, but in this case, we want to attack it all as efficiently and together as we can. So when we start the antibiotics, which the regimen is usually 8 to 10 days, we would also like to jump right in and do our root planing and curettage. We'd like to get our patient using the water flosser with hydrogen peroxide. We'd like to have the patient start using their electric toothbrush. We're going to have them start using an oral probiotic to try to compete with the pathogens in the mouth. So we're trying to do everything that we can to attack and eradicate these pathogens. If we're going to use not salivary, but if we're going to use oral trays, perio trays, then that's something that we would consider using upfront as well. And so, yes, we try, there is a sequence, but I would basically say we try to be as efficient as we can to do all of these things in a close timing of within a couple of weeks of all being done together.
Can you please advise the process for locating Airway focused orthodontics in USA for patients who need or inquire?
I'm sorry, can I help to identify where to find Airway focused orthodontists? Is that the question?
Advise process for locating Airway focused orthodontists for patients who need or inquire. Yeah.
So what I do is, if I'm looking for Airway focused orthodontists, I have some go-to referrals, but also friends that are very involved in airway orthodontics, like Dr. Bill Hang out in California. Others I could name all over the United States. So if I'm looking for an airway focused orthodontist, I would reach out to my colleagues around the country who are very involved in that discipline, who teach in their own teaching classes or academies, and seek their advice, for referrals. I'm not sure I answered the question, but I tried.
No, I think that was good. I think that was good guidance. Or how often we can prescribe the meds if it is needed?
When you say the meds, if we're talking about antibiotics, really our goal is to use antibiotics one time, eradicate the bacteria. What we'll do is come back about 10 weeks after our initial effort there, our therapy, and reevaluate, reassess the level of oral pathogens. We expect and hope that they'll be knocked down to a very minimal level, if not gone altogether. Then we have to put the patients on a maintenance program so that the disease does not return. And that's where we would use things like periodontal trays, oral probiotics, things like Stella Life, which doesn't destroy the healthy bacteria, but it does destroy those that we're after. And so that's a rinse. And then using things like hydrogen peroxide in a water flosser, et cetera. Those are very effective tools, and we've had great results maintaining health doing that type of approach. So as far as medicaments and coming back to them, we're really only using a medicament, I would call it, that would be antibiotics, and our desire is to only do that one time.
Do you recommend any water flosser products?
Well, as I said, we will recommend putting hydrogen peroxide in the reservoir of the water flosser. There are certainly other things that are very effective. So, there's a list of things, but basically what you're trying to do is to destroy and discourage those anaerobic bacteria from proliferating and thriving. And so rich oxygen environment, you could use ozone, water, for example, would be effective in a situation like that. And there are many other things. So there's a long list.
Last question is if you could share the link again for the IDM checklist.
Oh, yes. And so let me just go back briefly here on that right here, just so you see it. So if you go to 22828 and then you, in your text box, put integrative, then you'll have the list sent to you. So 22828, text integrative.
Perfect. Well, thank you so much again, Dr. Wilkerson.
Sure.
Wonderful
And-
presentation.
Well, thank you. Let me just close by saying that I would love to connect with you all more in the future in any way that I might be helpful to you. And we've also started a educational resource called IDM Scholar Society, as I mentioned before. So if you want to learn more about that, you can go to idmscholarsociety.com, where we're really trying to form a national collaboration of dentists, hygienists, nurse practitioners, and physicians that will be looking at this idea of integrative dental medicine. I certainly think that your academy fits right into that mold. I mean, that's what you are promoting. And so any way that we can collaborate, I would be thrilled to do so. So we can talk about that in the future. But if there's anything we can do to help advance your integration of these things, then you can check us out there. So thank you so much for allowing me, Shaylin, to be with you this evening and to share my passion. My goal is that dentistry would be the most respected specialty in all of medicine. And I don't think we have a lot of competition, honestly. And so I know we can do it. And I congratulate your academy for being leaders for these 37 or 8 years in this very field that we're talking about.
Thank you so much. Good night, everyone.
Take care, everyone. Bye-bye.